Hey, everybody. Here's the audio portion of the lecture, Urinary and Kidney Concerns. So if you have the PowerPoint printed off or you just want to follow online and make your notes separately, that's fine. However it works for you. I did upload the one that doesn't have the audio, so it might be a little easier to print off or something like that. All right, we're going to go through, hopefully this is just a review for you, going over some anatomy. If you really just don't remember any of the anatomy for the kidneys, get your anatomy book because again, it's always going to be right. It doesn't matter if it's 50 years old. The kidneys didn't move. Okay, so just use that. All right. So the renal system is the primary regulator of the body's internal environment. In cases where renal function could deteriorate, all the body systems are affected: heart, lungs, other organs, brain. Okay, they're all affected. Now, here's some stats to tell you about developing acute kidney injury. And by the way, acute kidney injury, or AKI, is the same as acute renal failure or acute kidney renal failure. They're interchangeable. The newest one is AKI, though, acute kidney injury, just so you know. Anyway, the statistics are anywhere from 1 to 13% of patients can be affected by kidney issues. It can be as high as 25% in critically ill individuals. And remember, back when we had a couple lectures in class, I will never test you on statistics. That's not going to happen. I'm telling you this just to tell you how prevalent this problem is. And now, along with those stats, mortality rates for those who are critically ill and develop acute kidney injury range from 30 to 70%. Mortality rate. That's really crazy. Now, what is your role as the nurse? Okay, your fundamental role when you're taking care of these patients is you must be able to recognize those who are at significant risk for developing AKI. So those would be people like your people that are dehydrated, those that have infections. So basically, I stated 99% of the hospital, right? So anyone could be at risk for this. Also, you want to identify preventative measures. You need to use the sharp assessment skills that we're trying to give you guys to provide supportive nursing care. Failure to rescue, whether you're an RN or a new grad, is very high in the fact that they don't know how to rescue. So that is a problem. Okay, so we're looking at the anatomy and physiology. We'll just go over this briefly. All right. The kidneys are upcoming a pair, obviously. They're extremely vascular. They're bean-shaped organs located in the retroperitoneal bilaterally area on either side of the spine. The right kidney sits slightly lower. So why do you guys think that might be? Because the liver is above it. Okay. As you remember, there is an adrenal gland on top of each kidney that produces aldosterone, which is responsible for what? What is aldosterone responsible for? Sodium and H2O balance. Each kidney has two regions, an outer region, which is the cortex, and an inner region, which is the medulla. And you have a picture here showing you this stuff. All right, so you might remember way back in block 1, I believe this is what was taught to you as well, that the basic functional unit of the kidney is the nephron. It is made up of a renal corpuscle, which is the glomerulus and Bowen's capsule and tubular structure. You can see here on your left, Bowman's capsule, the proximal, and over here is another one, and I'll be going over what this represents in just a minute, okay? There are around 1 to 3 million of these guys, these nephrons, most of which, 85% about, are in the cortex and have short loops of Henle. Okay? The remaining 15% of nephrons are located outside the medulla, and they're called the juxtamedullary nephrons. Okay. These nephrons have a long loops of Henle, which are responsible for concentrations of urine. So here's a long loop of Henle. Okay. The kidneys receive about 25% of all cardiac output. Now that may not seem a lot, but that equals approximately 1,200 milliliters of blood a minute that goes through the body. Now, just picture your liter bags that you guys were practicing with back in lab. 1,200 of those in 1 minute. I find the body fascinating. That's remarkable. Blood enters the kidneys through the renal artery, then through a series of renal branches, and finally to the glomerulus through the afferent arteriole. And here's the afferent, which is in. Efferent is out. Okay? Now, it leaves the glomerulus through the efferent. The glomerulus, and I'm sorry, I don't know why I get tongue-tied on that word, but I totally do. Glomulus. Like I can't pronounce the U or something. Sorry about that. Itself is a cluster. Let me restart again. The glomulus is a cluster of minute blood vessels that filter blood. When blood exits through the efferent arteriole, it enters very extensive capillary networks, tubular capillaries and vasa recta. These networks rejoin to form venous branches by which blood eventually exits the kidney through the renal vein. Okay? Now, what are some of the functions? Okay, so there are several functions to the kidney. Sorry, there was some background noise there. Okay, so this is a fairly comprehensive overview of the various functions attributed to the kidneys. There's only a few that we're going to go over. The regulation of fluid and electrolytes, pardon me, guys, excretion of waste products, regulation of the acid-base balance, and regulation of blood pressure. Now, renal prostaglandin synthesis, your last one on the right. I just want to tell you about this very quickly. In the cortex, major sites of prostaglandin synthesis include arteries and arterioles, as well as the glomulus. At these sites, the prostaglandins are important in maintaining blood flow and glomerular filtration, especially during conditions of enhanced vasoconstriction activity. So remember, constriction is tightening, dilation is loosening. Why am I telling you that? Well, we're going to talk more about GFR, or glomerular filtration rate, and this is where it all starts. It's the synthesis of the prostaglandin. Okay, so as blood flows through each glomerulus, water, electrolytes, and waste products are filtered out of the blood across the glomerular membrane and into Bowman's capsule, forming filtrate. Because the glomerular capillary membrane has a much greater permeability than other capillaries in the bodies, it can function at a highly efficient rate. Sieve. In other words, like sifting out the bad stuff. Normally allowing substances that possess a certain molecular weight to cross over. Now, the kidney filter is normally protein-free and contains certain electrolytes and nitrogen waste products. All right, and they're listed on the slide here, what the waste products are. Now, when you think about a pressure gradient, understand that is simply referring to the difference between the forces that favor filtration and the pressures that oppose filtration. Generally, the capillary hydrostatic pressure favors glomerular filtration, and the colloidal osmotic pressure and the hydrostatic pressure in the Bowman's capsule oppose it. That is filtration, that is. So because under normal conditions, capillary hydrostatic pressure is greater than the two rival forces. So in other words, You have two forces working against the one force. We want to filtrate. What I just said was basically the hydrostatic pressure in the one area, the capillary hydrostatic pressure, can overcome the other two opposers when the kidneys function normally. Now, when the kidney functions under normal, which is a GFR of 90, good to know what normal is. GFR above 90 is normal. If it starts to go under, they will produce approximately 180 liters of filtration a day. Let me say that again. I think I might have misspoke. The GFR, if it's 90 or above, filters about 100 liters a day. That's what I meant to say. Okay? A second process occurs, and that is the process of secretion. During the process, various electrolytes are reabsorbed or secreted at several points along the tubules. This process aids in regulating electrolytes within the internal environment. Finally, aldosterone and ADH are involved in water reabsorption in the distal convoluted tubule and collective duct. Antidiuretic hormone is ADH. You can see that on your screen there. Aldosterone also plays a role in sodium reabsorption and promotes the excretion of potassium. The remaining filtrate, which is about 1% of the original 180 liters a day, is excreted as urine for an average urine output of 1 to 2 liters a day. So that is A and P. That is how it works. Now, antidiuretic hormone. Antidiuretic. This can be confusing sometimes. Antidiuretic means no pee. That's how I remember it. I don't know why, but sometimes that concept can be a little challenging. Okay? So what is the role of aldosterone? Sodium reabsorption and promotes the excretion of potassium. Okay, because if your kidneys don't function right or well, this is why renal patients have high potassiums, because they cannot excrete it properly. Okay, that clear? If you need to take a quick look of how antidiuretic hormone works or something like that, there's a couple good YouTube videos out there that you can certainly search for if you need a reminder of how that works, okay? All right, GFR. We're going to talk about that. Okay, so here you have some categories that tell you. Now, don't get hung up on G1, 2, 3. I don't care about that. There's not going to be a question on the exam that I'm going to ask you about, what's G1. That's ridiculous. I'm not going to do that. But what you do need to clue in here is the GFR, the category that says GFR. See above 90, that's normal or high. Now, if it goes down, 69, mildly decreased, it's nothing to get up in arms about yet. This can be normal, especially as people age, their GFR goes down. Okay? Then you can go down and see where we're getting severe. Now look at clinical presentations. These are some of the things that can happen when someone is normal to mildly decreased, depending on the situation. Are they older? Have they been in some kind of accident? Are they dehydrated? Do they have an infection? All of this can create more problems in the clinical presentation. Then you look to the next box, mild to severe complications are listed there. And then kidney failure. This is a guide. Not everybody that is 45 to 59 are going to have those complications. They might be fine. But you need to know this because you need to know what, like I started at the beginning, potentially what could go wrong and what are you looking for? Okay, so let's say you have someone come in and their GFR is 62. And over in clinical presentations, these are some of the issues that could be a problem. So the first basic thing you're going to do is make sure you note their urine output and what the concentration is. Is it getting dark? Is there sediment? They're not filtrating, if that's the case. You're going to do a dipstick of urine. It looks like almost a pool dip. Well, it looks like a pool dipstick. When you dip the little colorful thing in the pool, and it tells you how much chlorine's in. Also, the NG tube. When we test for acidity, it looks like that, only it's for urine. And it can tell you whether they're what we call dumping ketones or protein in the urine. If you think back, I just talked about A and P and how protein should not be in your urine. This is indicative also of a diabetic. All right. But that's just an idea of where to go with this. All right. So regulation of acid-base balance. Alrighty. We're going to talk about some acid-base balance. Now, the kidneys help to maintain acid-base balance. Acid-base balance in 3 ways: by reabsorbing filtered bicarbonate, by producing new bicarb, and by excreting small amounts of hydrogen ions or acids that are buffered by phosphates and ammonia. The tubular cells are capable of producing ammonia to help with the excretion of hydrogen ions. So now when your patient is in a state of acidosis, the functioning kidneys attempt to lend a hand by producing ammonia and excreting hydrogen ions in exchange for sodium ions. And if the individual is alkalotic, bicarb is excreted at an increased level in the urine so as to decrease the serum pH. Okay, let's go over that again. If your patient is in a state of acidosis, the functioning kidneys attempt to lend a hand by producing ammonia and excreting hydrogen ions in exchange for sodium. And if the individual is alkalotic, so their pH should be what? Above 7.35, alkalosis. The bicarb is excreted at an increased level in the urine so as to decrease the serum pH. So if you have somebody that's at a 7.45 pH, they're alkalotic, right? So the kidneys are like, I need to get the bicarb out. So you're going to have more bicarb in your urine so you can decrease 7.45 back down. So, that's still within normal range. But anyway, if they're alkalotic, 7.5, let me give that one. Sorry, guys. 7.5, they're going to excrete bicarb, so you're bringing it down into more of a normal range. You're alcoholic, oh my gosh, alkalotic, then you need to decrease it. Make it go toward the acid area to make it normal. Okay, regulation of blood pressure. Okay, so regulation of blood pressure. Oh, I'm sorry, you guys. I don't know why I hit that. I didn't mean to. All right, regulation of blood pressure. All right. On the right is a flow diagram of the renin-angiotensin mechanism. So let's look at how this relates to renal function and the regulation of blood pressure. There are specialized cells in the afferent and efferent arterioles and the distal tubular. Oh my gosh, you guys. I'm telling you, been very long days. These cells are collectively known as the juxtaglomerular apparatus. Say that 3 times fast. I actually practiced that and it still didn't come out very well. Okay, they are responsible for the production of a hormone called renin, which plays a role in the regulation of blood pressure. Renin is released whenever blood flow through the afferent and efferent arterioles declines. when blood flow declines. Another reason for renin release is a decrease in sodium of the blood flowing past these specialized cells. For example, if the blood flowing through the specialized cells decreases, this could be because of someone's hypovolemic. They're either bleeding out or dehydrated or something like that. Once renin is released, it activates the renin, angiotensin, aldosterone cascade, shown on the right. This now causes the production of angiotensin II, resulting in vasoconstriction and release of the aldosterone from the adrenal glands. All of this in place will have a positive effect on raising BP and increasing sodium and water reabsorption in the distal tubular and collecting ducts. Now, angiotensin 1, angiotensin 2 as related to what kind of blood pressure medications? I'll let you answer that. You should know that one. And if you don't, email me, okay? All right, effects of aging on the renal system. All right, as we get older, like I mentioned before, it decreases the GFR. The most significant change that is noted within the renal system during the process of aging is a decline in the GFR, like I just said. I don't know why I had to say that twice to you guys. Research indicates that after the age of 40, reductions of 8 to 10 milliliters a minute occur from each decade of life. This is due to several things: reduction in renal mass, reduction in the number of glomerular, and reduced blood flow. It's interesting to note, though, that the serum creatinine levels do not demonstrate changes. So, your creatinine and your BUN, are one of the first things that you're going to see in renal issues. But when you get older, you may have a decrease in GFR, so your filtration rate might decrease. However, your kidneys are still functioning because your BUN and your creatinine are normal. Okay, I believe we talked about that too. When your BUN goes up, usually you just are dehydrated. If your BUN and your creatinine go up, then they're starting to have some kidney involvement. All right. Where was I? Oh, you will also note that the ability to concentrate and dilute urine will change because the renal tubulars have less ability to maintain the osmotic gradient in the medullary area of the kidney. That's just the anatomy of it. Okay. Now, the tubular change affects the countercurrent mechanism, which significantly alters sodium conservation. Think about the significance of this if the patient is already on a sodium-restricted diet. It's kind of crazy. Everything affects everything else. All right, so they're already not getting enough sodium because they're on a restriction, and now it's even worse. We still need sodium to live, guys. Salt's not always the enemy. Other changes your older adult patients will experience is the ability to effectively excrete certain medications. Radio contrast dyes may require a lower dose because if you give it at the regular dose and there's some kidney involvement, they can get nephrotoxic, which means damaging the kidney. As renal function declines, antibiotic dosing may need to be reduced because they're not filtrating it as well. So think about when you review medication orders with your patients. That, again, is where the rubber meets the road. Are they going home on normal doses of items that are already in their system? It's all that thinking ahead. All right, now fluid and electrolyte abnormalities often occur as well. It's a result of the decreased renin and aldosterone levels. Renin levels can decrease anywhere from 30 to 50% in older adults, resulting in a decreased angiotensin II production and lower aldosterone levels. So think back to the cascade we were talking about. Renin levels, when combined with this, a patient can be hyperkalemic, which is high potassium, which can cause what in a patient? What abnormalities? Cardiac abnormalities. A decreased ability to conserve sodium, and an increased tendency to develop volume depletion and dehydration. Older adult renal function may be less to correct acid imbalances. This can result in prolonged metabolic acidosis states with subsequent shifting of potassium out of the cells and increasing hyperkalemia. The slight increase in ADH production that occurs with aging, and that's normal, along with a decrease in responsiveness to ADH, may worsen volume depletion and dehydration. Okay, so what does that mean? A slight increase in ADH, so their anti-P is going up. Okay, so you're thinking, wait a minute, didn't you just say it worsens volume depletion? I did. This is why. Just because geriatric patients have an increase in the ADH production, the hormone, the anti-P hormone, means I'm not going to pee right now, is increased. However, when we get older, the body doesn't respond to that. It's like it's ignoring it, going, I'm old enough, I'm going to do what I want. So then it doesn't hear it, the anti-P, so it goes ahead, and then they still urinate when they shouldn't be. It's not responding to it. So your ADH levels can be high, but a geriatric patient may not respond to the signals of the body. Okay? All right. Pyelonephritis. All right. Pyelonephritis is a very common renal disease affecting about 6 times more women than men. Geez, ladies, aren't we lucky? The primary risk factor is in one who has numerous or pre-existent UTIs, urinary tract infections. The primary risk factor. People treat UTIs like it's not a big deal, and it is a big deal because it can turn into kidney problems. Also, if you're older, especially in the geriatric population, not that it can't happen in people that aren't in the geriatric population, but it makes you loopy. You have a decreased ability in your cognitive response to things. I need to take a quick drink. Sorry, guys. Fortunately, it's just water, but you gotta do what you gotta do. Okay. Pyelonephritis is an inflammation of the rena, parenchyma, and urinary collecting system. It is most commonly caused by a bacterial infection that happens as a result of contamination of the urinary meatus and bacteria found in the GI tract. Basically, guys, ladies, I should say, you need to wipe right. Okay? Front to back. If you bring it back to front, you're getting all that GI stuff up in there. It's icky. Now, what are some of the clinical manifestations? Fever and chills, nausea, vomiting, back or flank pain over the costovertebral angle tenderness. Oh, God, it's late. Sorry, guys. Or the CAT, and I have a picture to show you of that. Or CVAT, I should say. The pyelonephritis is normally diagnosed by a thorough history and physical, as well as lab tests. The lab tests include a urinalysis. You're looking for pyuria, bacteriuria, hematuria. Pyuria is purulent or pus. Bacteriuria is infection, right, in your urine. Hematuria is blood. Then you're also going to get a urine culture, a blood culture, and CBC. You're specifically looking for leukocytes on that one. Some hospitalizations may be necessary. Pregnant women, it poses a risk for premature labor. Older adults or the severely ill. Those with comorbidity conditions, to prevent any possible complications, you need them hospitalized. Outpatient treatment is acceptable for the mild or moderate illness, or if you don't have a comorbidity. Whether hospitalized for treatment or treated on an outpatient basis, PO or IV antibiotics will be ordered, usually a broad spectrum, meaning we're covering all kinds of cooties that could be in there. Usually it's Bactrim or Cipro. Fluid therapy, either PO or IV, depending on the severity of the case. It is painful. Normally NSAIDs are given, but in the severe cases, narcotics could be prescribed. Antipyretics as well. What's an antipyretic? For fever. Okay. And a urinary analgesic, phenazopardine, which I cannot, I'm sorry, you guys, I am like having problems today. Could be prescribed, just no urinary analgesic. Okay. I'm telling you, I can't speak anymore. All right, I'm going to go to the next slide. All right, so you have a picture of the ZVTA, and that is where the pain can be located. And on the right is pyuria. And remember, what is it? We never document the word pussy. You're right, because we just don't do that, and you can figure out why. All right, glomerulonephritis. It is the third leading cause of renal failure. All right, glomerulonephritis is classified as either acute or chronic. The acute form developed very quickly, usually as a secondary problem from an infection. The chronic form may result from the same reasons as the acute form, but may be genetic in nature. It develops over a longer period of time and often results in some level of permanent kidney damage. That's the chronic. The renal system develops an increase in permeability to protein. So proteins will be identified in both the blood and the urine. Patients are likely to present edematous with a marked decrease in urine output and hypertensive. And why is that? Because they're holding on to fluid, right? They can't get rid of it. Good. Medical management of the glomerulonephritis will include the use of a penicillin normally. And you guys, when people say they're allergic to penicillin, that's why it's so important to ask what happens. Because if it's just a rash and penicillin is the best treatment, like in this case, penicillin really is the best way to go, we're just going to give them Benadryl. Now, if they say they have an anaphylactic reaction, their throat closes, and obviously we're going to avoid penicillin. But that's what a good example as to why we always ask what happens. All right, the next thing that for medical management is a diuretic or another antihypertensive. Sodium and fluid restrictions to combat the edema. If the BUN is elevated, there may be an ordered reduction in dietary proteins. BUN increased? Yeah, probably will be. And corticosteroids are not always recommended, but may be indicated to lessen the inflammatory response. Why are we decreasing dietary protein? Because we've got protein spilling into the urine and the blood flow. They have enough. Okay? All right. Urolithiasis. Forgot where I was for a minute. Oh my gosh. Urolithiasis is the calcification in the urine system. It's kidney stones, guys. Okay, it can be in the urine or the bladder. Kidney stones affects about 12 individuals for every 10,000. It occurs more frequently in males than females. Okay, guys, that one's yours. Greater in Caucasians than African Americans. Okay. In the summer month, where humidity, sweating, and dehydration are more common, it occurs. It can be a family history or dietary habits, increase in sodium intake, for example. The most common manifestation is significant pain. Sorry. And the location of the pain depends on kind of where it's occurring in the body. Upper ureteral stones, you'll have flank pain. Lower ureteral stones, you'll have lower abdominal or genital pain, and some pain on urination, also known as dysuria. Nausea and vomiting frequently accompany this pain. Gross hematuria is common in about 95% of the patients. Now, medical diagnosis is relatively simple. Non-contrast CT is the modality that we choose. CTs can identify the calculi and any obstructive uropathy. For example, hydronephrosis, which is swelling of the kidney. A KUB, also known as the kidney ureter bladder, is an X-ray that is relatively inexpensive, but it can only pick up calcification of stones, not uric acid stones. So it is limited in that piece. Understand that most stones of less than 5 millimeters, which is still a good size, by the way, will pass spontaneously without any hydronephrosis or infection or anything like that. Still pain, but it can pass on its own. Narcotics and NSAIDs, along with antiemetics, will be commonly prescribed while the patient's passing this. Okay. Alpha hydrogenetic blockers like Flomax are used to help relax the ureter, thus promoting a greater opportunity for the stone to pass. If you're more relaxed, I mean, just think about, you guys, when you're trying to pee, if you're all stressed and everything, it just gets sucked up because your body goes into fight or flight. Okay. Now, any surgical management, you'd have a uroscopy, percutaneous nephrolithotripsy, there's the nephrotomy. Now, to monitor for complications, you'll be looking at renal function. For example, is their BUN and creatinine increased? They might have to go for a ureteral stent or a nephrostomy tube. All right, here's an example of a ureteral stent. This picture here shows you how it goes in and travels. And then over here is the picture of the little area there. Okay. Nephrostomy tube, here's a picture of how it goes in. Here's a real patient. This bag happens to be taped on the patient. Surgical interventions, the percutaneous, which I don't know what's wrong with me tonight. The otomy, this is how they look. They look into it, and it's going into the kidney. All right, and the uroscopy, yep, that's where it goes, right there, to take a gander. And I'm not sure how many patients actually look at this, because believe me, you need to deep breathe when this is happening, for sure. All right, we're going to talk about urosepsis. Okay, urosepsis is a systematic reaction of the body to a bacterial infection of the urogenital organs with the risk of life-threatening symptoms, including shock. Now, basically, a system reaction to the body is called SIRS, S-I-R-S. It stands for Systematic Inflammatory Response Syndrome. In an inflammatory response as a result of the significant infection from a damaging organism. Now, statistics indicate that around 1 million cases of sepsis occur each year, with an economic toll of about 17 billion. Mortality rates are as high as 40%. Excuse me. Oh, it just went a little nuts here, the recording. Okay. Your patients will present with a variety of symptoms. Most common is hypotension and tachycardia. That's not so surprising, right? Because in sepsis, they're hypovolemic or dehydrated. Your patient may have a fast respiratory rate and have either an elevated temp or be hypothermic. Now that sounds a little odd, but most sepsis patients have an elevated temp. When they're hypothermic, it's called cold sepsis, which is a problem because if you can't sweat, then you're not fighting the infection. So it's a problem. Signs of organ hypoperfusion would be oliguria, hypoxemia, and an increased lactate level. Patients' labs usually show leukopenia, All right. And if you look down here where it says oxygenation, heart rate, tissue perfusion, mental status, all right, these are the things that are triggered: lack of oxygenation, increased heart rate, your tissue perfusion declines. So your cap refill, for example, would be above 3, and your mental status. Usually the mental status is the first thing you see in people when they have a sepsis. It starts to decline. It could be very subtle. It could be all of a sudden they don't remember your name. And you might think, oh, well, they just forgot it for a second. Because it might be, do you remember my name? And they look at you for a minute and go, Kath, okay. It's Kathy, that's right. That could be how it is. And you just kind of, tick it off the list. They're older, whatever the reason is. But you have to look for that stuff. Now, careful ongoing nursing assessment is critical if you're going to identify the early stages of sepsis before septic shock ensues. Okay? You'll be looking for often very subtle changes, just like I said. As your patient begins to deteriorate, respiratory rate will rise in an attempt to compensate for the decreased tissue oxygenation. Your SATs will begin to drop, requiring that you increase oxygen levels in order to maintain adequate saturation. So your pulse ox. Heart rate will rise in order to maintain an adequate cardiac output. Regular BP may not be as diagnostic as a mean arterial pressure. What that means is, let's say they have a blood pressure of 120/80, and the mean pressure is 68. It's that middle number. So most people now, or most physicians now, go by the mean arterial pressure, not systolic. You might still see some docs saying keep systolic blood pressure above 90 when you treat this, but most of the time they'll say keep the mean arterial pressure, or the MAP, above 65. Above 65 usually perfuses the body really well. I believe, I know for sure in trauma patients and septic patients, it's above 70, and I believe in cardiac, it's above 70. You'll get more of that in block 4. All right. Urine output will decline. Why is that? Why do you guys think? Because they're dehydrated, right? So the body's going to keep any fluid, even waste, because it can reutilize it. But the biggest thing is mental status. So how are we going to treat it? So the diagnosis of a UTI from simple cystitis to complicated pyelonephritis, sepsis can be recognized by urine cultures. So what I'm saying is, if someone has a UTI, they can develop urosepsis. If they have cystitis, they can develop urosepsis. If they have pyelonephritis. Okay, so this is all stuff that can happen. Nothing's benign. But a lot of the stuff we can recognize with a urine culture. So where did it start? Urine specimens must be cultured properly within 2 hours after collection or be preserved in a refrigerator. So basically what I'm saying is, if you get a urine culture, it needs to go down to the lab immediately so they can run it. Okay. Otherwise, usually what we do is we put it in a fridge, and of course it's separate fridge than where your lunch is, okay? We put it in the fridge, and then when lab comes around to do their pickups, they look in the fridge to pick things up. Some patients with severe urosepsis may develop bacteremia. All right, microbiology, proven infection can be identified as many as 70% of the patients have bacteremia. That's what that sentence means. Adequate organ perfusion must be safeguarded. Hypotension is managed initially with IV fluids. Remember when we talked about crystalloids and colloids? This is the patient you're giving normal saline to, probably 2 or 3 bags before you hang a colloid. If needed, to hang a colloid, you got to make sure, I don't even think that was English, you have to make sure, okay, that they are hydrated. Okay? Now, the urine output rate should be kept greater than 0.5 milliliters per kilogram per hour. Your urine output rate should be kept at greater than 0.5 milliliters per kilogram per hour. Okay? Okay. Urine output rate should be kept at greater than 0.5 milliliters per kilogram per hour. I think that might be important. I'm just throwing that out there. It's no longer just 30 milliliters an hour. It is 0.5 milliliters per kilogram per hour. That is what the patient should be outputting per their weight. Okay? Vasopressor therapy. We might be using dopamine, dobutamine, or norepi, which is also called Levophed. It may be indicated along with IV therapy. All you need to know is vasopressor therapy. Okay? Ventilator support will be instituted for patients with progressive hypoxemia. Unfortunately, a lot of sepsis patients, they end up in septic shock and they need a ventilator. Okay. We also put them on a ventilator because of respiratory muscle fatigue. Didn't I say that the respiratory rate would be increased? Well, some of these people can be as high as 60. Could you imagine breathing at 60 times a minute? You'd get exhausted, right? And it's not adequate for getting the satisfaction of a deep breath in and oxygenating all the tissues. We don't want someone just to conk out just because their muscles are tired. So if we can put them on a ventilator to help that, we will. Blood sugar levels should be maintained at less than 150 during initial few days of severe sepsis. They're going to have high sugars because they're stressed. Antibiotic therapy effect against both gram-positive and gram-negative bacteria should be initiated. So an antimicrobial of choice will be reevaluated once culture results come back. Now, what that means is basically we're going to put them on a broad spectrum antibiotic of some kind until we get the results back, which normally takes 48 to 72 hours. Then we will switch this treatment for specific antibiotics. All right, now we're going to talk about overall acute kidney injury. What we just talked about in those first few slides there, we talked about other diseases of the kidneys. Now we're going to talk about acute kidney injury. All right, I told you the term acute kidney injury has now replaced acute renal failure because AKI is considered a much broader term and it includes multiple levels of severity. So you're going to hear them interchanged out there. AKI is very serious and you will, see frequent clinical occurrences in the ICU environment, not to mention the med-surg environment. Even mild forms of AKI have demonstrated very high mortality rates. Acute kidney injury is described by a rapid loss in kidney function, confirmed by a rise in serum creatinine or reduction in urine output. Now, we talked about that. If your BN goes up, it's probably just because you didn't have enough water that day or enough to drink. If your creatinine is also increased, then we're starting to involve the kidney itself. Okay? You will also see a decline in the GFR. Remember the filtration rate? That results in retention of nitrous waste products. That's a term called ozotemia. AKI will develop in hours or days. During this time, you will note a rise in the BUN, then the creatinine, and then potassium. Why? Because potassium isn't being excreted. There may or may not be reductions in urine output at this point. This is the beginning. There are a number of pathophysiological conditions that can lead to the rapid development of AKI. These conditions or causes are classified in 3 pathophysiological states of ozotemia, and they are to the left: pre-renal, intrarenal or intrinsic, and post-renal. All right. Pre-renal, caused by a decrease of renal perfusion often because of volume depletion. Right here, sepsis, volume depletion. Look at the causes. Bleeding, poor cardiac output. Okay, intrinsic, caused by a process within the kidney. So again, you could have renal ischemia. Now it says necrosis from sepsis. So they're septic here, and then something happened to the kidney. Look, here's mean arterial pressure. Now this says below 70. All right, but they've had to have been below 70 for a little while to create ischemia. All right, and then of course multi-system failure. Then you have postrenal, caused by inadequate drainage of the urine distal to the kidneys. This would be your kidney stones. Something is blocking it. It could be a tumor. It could be a congenital defect. Okay, pre-renal, intrinsic, postrenal. Hold on, let me go back. It's also here. It's on both of them. I think that's important to know. Okay. All right. Pre-renal causes of AKI are related to causes outside of the kidney. These are factors that cause a decline in renal blood flow and lead to a drop of the filtration rate. Although the functions of the tubulars and glomerulus are maintained, filtration is reduced as a result of decreased perfusion. So up here on pre-renal, you have renal hypoperfusion, you get hypotension, decreased cardiac output, and decreased effective arterial blood flow. All right? Okay. So basically, Olgueria is present, but there is no damage to the kidney tissue. Not yet, anyway. It is simply a result of a decrease in circulating blood volume, dehydration, decreased cardiac output, burns, and it's usually reversible in pre-renal. You must remember that pre-renal conditions have the potential to lead to actual intrarenal diseases if the ischemia extends over time. So you don't want it to get to intrarenal or intrinsic. Now, intrarenal causes of AKI are conditions that cause kidney tissue injury with subsequent reduction in nephron function. Nephron, brains of the kidney. Again, prolonged ischemia, nephrotoxic agents like contrast media dye that we use in CT scans, amnioglycotics. Okay, amnioglycotics are poorly absorbed from the GI tract and distributed mainly in the extracellular fluids. Okay, high concentrations can be found in the renal tissue, particularly the renal cortex. Nephrotoxins may crystallize, causing the obstruction, or they can damage epithelial cells of the tubulars. Contrast media causes long-standing vasodilation, resulting in a decrease in oxygen delivery and subsequent ischemia injury. I'm seeing a trend. All right, so there you go on the slide. Kind of what I'm talking about. Right. Now, acute tubular necrosis is the most common cause of AKI. Okay, that's ATN right here, the 50%. Necrosis is never good in anything. It is usually a result of ischemia, nephrotoxins, or sepsis. Ischemia causes changes in the basement membrane and irregular damage of the tubular epithelium. Nephrotoxin agents cause necrosis of tubular epithelial cells, causing them to shed and obstruct the tubulars. I don't know why I always add an R in there, but I do. ATN is a condition that has a possibility of reversal if the basement membrane is not destroyed and the tubular epithelium is able to regenerate. So basically, if it hasn't gone all the way through and basically died, then we could reverse it. Okay. And then postrenal. Mechanical obstructions that interfere with the outflow of urine are the cause of postrenal conditions. As urine flow is obstructed, it creates a backflow into the renal pelvis, impairing renal functions. So there are some of the issues that can happen. Here's a list of nephrotoxic medications. Now, if you guys are looking at that, I think you have an idea that holy shnikes, it's just about everything that I could possibly take. The only good news is, even though it's not a medication, I consider it a medication, that chocolate is not on there. So yeah, everything. I don't think it's too crazy that cocaine, heroin, and meth is a problem. But look at some of the ones we use, ACE inhibitors. Oh my gosh, right? Rifampin, cephalosporins. It's incredible. It's a lot of things there. All right, the stages of AKI are listed here. Risk, injury, failure, loss, end-stage kidney disease. This is a classification system known as RIFLE. Can be used to identify kidney injury and outcome. It is used to standardize the diagnosis of AKI. Risk is the first stage, followed by injury, and then an increase in severity leads to failure. There are two outcome variables, those related to loss of a kidney function and end-stage renal disease. I think this is something that you guys need to be familiar with, okay? It's very helpful. All right, phases of AKI. AKI may have lengthy progression. I just lost my train of thought. Acute kidney injury progresses through 4 separate phases. All right, you've got onset, but most commonly we look at the oliguric, the diuretic, and the recovery phase, not so much the onset. Okay, the oliguric phase, urine output decreases from renal tubular damage. Hyperkalemia is common complication of acute kidney injury, particularly in oliguric. Hyperkalemia may be worsened by the influx of potassium out of the intracellular compartment. We talked about that before. If the kidneys aren't functioning, potassium is going to be released in the system. And you guys listen on here are the features of what each one could say and how long it may last. The diuretic phase, the kidneys try to heal and urine output increases, but the tubular scarring and damage has occurred. And the recovery phase, the tubular edema resolves and renal function improves. Those are the 4 stages of AKI. Hopefully they improve. If not, then they end up with dialysis or a transplant. Okay? Phases are good to know. So, assessment. There are specific aspects of a patient history that must be discussed, okay? Unless you ask specific questions, you may not elicit the pertinent information from the individual or the family or whoever's with them supporting them. Renal-related symptoms provide valuable information that will assist you on focusing on the assessment that you need to do and how to look out for these patients. Okay, so for example, have they had dysuria? Frequency, which means, peeing a lot. Incontinence, nocturia, not peeing at night. Pyuria, does it burn? Hematuria, blood. These can be indicative of UTIs. Histories provide information on medical conditions that predispose the patient to acute renal failure or acute kidney injury, whichever term you want. This includes diabetes, hypertension, immune diseases, and any hereditary disorders like polycystic disease is inherited. Excuse me. The medical record must be carefully reviewed to identify additional risk factors, such as hypotensive episodes and surgical or radiological procedures in recent history. You must make an attempt to identify any exposure to nephrotoxic agents, the medications, for example, we saw, the CT dye, any of that stuff. Symptoms of nephrotoxicity will usually manifest for 1 to 2 weeks after the exposure. So it doesn't happen immediate. You must be clear to patients, pardon me, about the need to identify recent medical therapies and ask specifically about over-the-counter medications. Change in blood pressure is common in AKI. Those with prerenal causes may be hypotensive and tachycardic as a result of volume deficits, decreased fluid. Hypertension may indicate the ATN, the necrosis, particularly if allogoria is present. Hyperventilation may signal the respiratory system's attempt to compensate for the metabolic acidosis, often noted in acute renal failure. If uremic toxins often cause an antipyretic effect, resulting in lower than normal body temperatures. So they're not going to spike a temp. If infection is the culprit, then temps will be elevated. Is it just something in the kidney, like a polycystic issue, or do they have an actual infection? That's what that means. Okay, head to toe assessment. Sorry, guys, I need to take a sip. Okay. All right. Your thorough physical assessment is a critical component of the necessary care required. Now, I know most of you did not get to go into the hospital and clinical, and I'm sorry about that. Wish there was something we could do about that. I really do. But when you are out there, and you know this from your first year in nursing school, people take shortcuts. And that's really not okay because you're missing a big picture. So you want to make sure you've got your head to toe assessment skills down. All right. Now I'm going to mention a few items in here. The cardiovascular, you're going to assess for heart failure, pulmonary edema, peripheral edema, and hypertension. Makes sense. Hematological, you're going to evaluate for anemia, alterations in coagulation, and an increase in susceptibility to infection. Alterations in coagulation, are they bruising? Anemia, are they bleeding anywhere? Okay, increased susceptibility to infection, are they compromised? Do they have a comorbidity like cancer that could leave them more susceptible? Then you're going to look at electrolyte imbalances, as seen in AKI, often result in metabolic acidosis. The respiratory system evaluation may provide suspicions of pneumonia, and auscultation and respiratory effort may indicate pulmonary edema. So if you're hearing crackles, if the patient's respiratory rate's elevated, okay? When looking at the GI system, assess for anorexia. Have they not eaten? Not the disease, just have they not eaten? Nausea and vomiting. Stomatitis. Stomatitis is sores in the mouth. Uremic halitosis, which is bad breath. Look for signs of gastritis, and bleeding. Now, from a nausea vomiting standpoint, look for drowsiness, confusion, irritability, coma, tremors, twitching, and convulsions. All of these are a result of uremic toxins, electrolyte imbalances, and acidosis. So your psychosocial assessment may demonstrate decreases in their mental status, in concentration, and alterations in their perceptions. Now remember, guys, just because people are older doesn't mean they have Alzheimer's, and it doesn't mean that they have dementia. What are the big things you need to already know before you come to the conclusion that they have a disease process? What it is their sodium low? Do they have a UTI? Is the blood sugar high or low? Is the pulse ox low? Is their ammonia high? All of those can cause problems with mentation, of course, and as your kidneys. Carefully examine the skin for signs of pallor, yellowness, dryness, uremic frost, and I'll show you uremic frost in a little bit. Okay, glucose intolerance. Usually it's not clinically significant, but when conducting the skeletal assessment, keep in mind issues with hypocalcemia. You don't have enough calcium in your bones, then your bones become brittle. Okay, lab values. Let's go over those. Serum creatinine, BUN, all this fun stuff. Okay, because the renal system is the primary regulator of the internal environment of the body, as we talked about at the beginning, Any change in function is often seen in serum and urine lab values. Now, serum creatinine is used to evaluate renal function. Creatinine is a byproduct of muscle metabolism and is produced at a relatively constant rate, then cleared by the kidneys. Under normal conditions, production and excretion are well balanced. So as the kidney function diminishes, meaning it's not doing well, the creatinine elevates, the kidney function. However, creatinine should not be the only assessment measure for renal function. A similar level may be reflective of a very different GFR. Okay? And we'll get to that. BUN is also a helpful guide to determining actual renal function, but not as reliable as creatinine. This is because the rate of protein metabolism, which is urea as a byproduct of protein, it's not constant. Elevations in BUN can also result from dehydration, high protein diet, starvation, blood in the GI tract, corticosteroids, and fever. So there's other reasons why BUNs can be evaluated. So you need to look at your patient's whole picture. Remember that with GI bleeding, blood is broken down, causing an increased protein load, and hence the elevation of a BUN level. The BUN creatinine ratio is a relational indicator between BUN and creatinine levels. Now, a normal BUN creatinine ratio is 10:1 to 20:1. Example, BUN 20 milligrams per deciliter and creatinine 1 milligram. Okay, so that's where you get 10:1, 20:1. Creatinine clearance levels are obtained through a time-consuming process of collecting exact 24-hour urines. Creatinine clearance is an estimate of GFR, which is the filtration rate, and is measured in milliliters a minute. The normal creatinine clearance is about 84 to 138. Now, serum creatinine alert. The same serum creatinine level can reflect very different filtration rates in patients because of differences in muscle mass. So there's a difference between your serum creatinine. For example, a 25-year-old man weighing 220 pounds with a serum creatinine level of 1.2 has an estimated GFR of 133, which is normal. Whereas a 75-year-old woman weighing 121 pounds with the same serum creatinine level of 1.2 has an estimated filtration rate of 35. It's markedly decreased. So because creatinine is based on muscle breakdown, that's why you get that big difference. Okay, this is in relation to the creatinine levels. All right. I'm sorry, guys, I had a cough again. All right. Moving on, more lab values. All right. Analysis of urinary sediment with electrolyte levels is extremely helpful in distinguishing among the various causes of acute kidney injury. Urine should be examined for the presence of cells, casts, and crystals. In pre-renal conditions, urine may not have cells, but may contain hyaline cast. This is caused by proteins, precipitate in the distal tubulars, and collecting ducts. Post-renal conditions may present with stones, crystals, sediment, bacteria, and clots. That's an obstruction. A coarse, muddy brown granular cast in a classic finding of necrosis, along with microscopic hematuria. That's why it's important to get this stuff to the lab so they can look at it. Electrolyte levels can be helpful to differentiate between pre-renal causes and necrosis. You may be obtaining urine samples before you give diuretics because you want to see what's really going on. You don't want, it's like hanging an antibiotic before you get cultures. You want the real picture before you give diuretics that can stimulate the kidneys to work. Urine sodium concentration is usually of 10 milliequivalents or below are noted in pre-renal conditions. As the kidneys attempt to conserve sodium and water, to compensate for their hyperperfusion state. Fractional excretion of sodium, FENA, is helpful to determine how effective the renal system is at concentrating urine and conserving sodium. In prerenal conditions, the FENA is low, and in ATN, it's elevated. So again, prerenal conditions, or is it necrosis? Urine-specific gravity and osmolality has a limited diagnostic role, honestly, particularly in older adults. As the body ages, the ability to concentrate urine diminishes, plain and simple. In general, prerenal conditions cause concentrated urine, high specific gravity and osmolality. And an intrinsic azotemia causes dilute urine, low specific gravity and osmolality. Now you're like, geez, Kathy, what the heck did you just tell us? Okay. Let's say I tell you guys, you have a patient that has an abnormal urine-specific gravity and they're 70 years old. Would you take that to gospel that they have a kidney problem? No, I just told you it really doesn't matter because of that issue. What if I said to you that in a your fractional excretion sodium FENA, I'm just throwing this out. This is not a real question. This is what it might sound like. Okay. You have an FENA, okay, that is low. Could this be necrosis? Could this be a prerenal condition? Intrinsic? Alguria? Well, I just said that if it's low, it's prerenal condition. It's elevated in ATN. Those are the kind of questions or similar to that I'm asking. Okay? Now, geriatrics. Now, there are some specific things to consider when providing care for older adults. Okay, they're at increased risk for renal failure due to comorbidity conditions that frequently exist in this population. As the kidney ages, it becomes more vulnerable to the nephrotoxic and subsequent ischemia that medications can have. The primary risk factor for contrast-induced nephro issues in a pre-existing decline in renal function. This places the elderly individual at risk. Older adults are more prone to develop volume depletion, which is prerenal conditions, because of a decreased ability to concentrate urine and conserve sodium. In line with this, urine are the limited value in assessment of older adults because of the impaired ability to concentrate urine. Older adults may exhibit uremic symptoms at lower levels of serum blood, urea nitrogen, and creatinine than younger adults. When you consider atypical symptomology, older adults really may present with unexplained exacerbations of previously well-controlled heart failure, for example, unexplained mental status changes, or personality changes. Older adults may have poor nutritional status before AKI and require early and adequate nutrition. Renal replacement therapies may need to begin earlier because older individuals become symptomatic with lower creatinine and BUN levels. Supplemental O2 may be necessary at the start of dialysis, and monitoring for abnormal bleeding with systematic heparinized may be required. Immune system efficacy declines with age, which makes these individuals more susceptible to infection. So a lot of things going on there with the geriatric patient. All right, some diagnostic procedures. There are various diagnostic procedures here. There's non-invasive and invasive. Some of the non-invasive diagnostic procedures that assess the renal system are listed there. All right. A KUB delineates the size, shape, and position of the kidneys. It may also identify abnormalities such as the calculi or kidney stone that we talked about. cysts, or tumors. A renal ultrasound is useful for evaluation of the urinary collective system. So you could see an obstruction possibly. Okay. An ultrasound will also show the size of the kidneys. Ultrasound is used during renal biopsies, which of course then would make it invasive. These are interchangeable. You'll see over here on the right where it says invasive, it says CT. The second one down is a CT scan. Normally they're not invasive, but if you start an IV and give dye, then it's invasive. Okay. All right. So here's some examples. Okay. Here's the intravenous pyelogram, kind of what happens, what the renal biopsy would be like. All right, so what are nursing interventions? They're very broad, but people that commonly have urinary issues, they're weighed daily, even if they're in ICU unconscious. Maintain strict I&O. Now, you'll see that written. You should always do strict I&O. It is not a guessing game. You need to measure it, for sure. Sometimes you have to set your pump. I'm still in this habit. People don't do it as much anymore, but every time I come in shift, I clear the pump so it doesn't have a history of what happened the shift before. So I know exactly what they got. I don't just say, oh, they're getting 100 milliliters an hour. What if I stopped it for some reason? Or they got something else before? You have to make sure this stuff is really strict. All right, frequent assessments of the lungs and the cardiovascular system. You're going to take a look at the ankles, right? Make sure there's no edema or anything. Lab results, super important. Avoid invasive equipment, bleeding, because you don't know what's causing this. Of course, good hand washing, especially in the world we're living in now. Can't believe we still have to tell people to wash their hands. Oral hygiene. Now, with oral hygiene, every 2 to 4 hours, well, in the ICU, it's every 2 hours. Now, good oral hygiene. Not just a little green swab with water on it. We actually have things set up to a suction unit and brush their teeth and their tongue, because that is where the creepy crawlies get in, you guys. It sits in your mouth and then it crawls down into your lungs, your heart, all that jazz. It's kind of disgusting if you ever saw it. All right. One last thing here, always let the patient and families know what you're doing. Goes a long way. Prevention of AKI. Now, proactive approach would be great. When you know that an nephrotoxin are major culprits in AKIs, then keep that in mind, when you're educating your patients, should they be on them. There have been a number of clinical studies over the last decade regarding the benefits of using an isoosmolar radiocontrast agent over a low osmolar counterpart. It appears that all these studies are either inconclusive or show relatively little benefit in terms of elevation in serum creatinine and the development of chronic renal failure. So basically, what this says is there's no evidence that regular contrast dye is any worse than low, which is the one they develop because of people in kidney issues. We want to give them dye to see what's going on, but yet if we give them dye, that can shut down your kidneys. That's all I'm saying about that. That's just an FYI. But it is important to monitor the blood levels in those that have gentamicins, any of the iacins being administered. ACE inhibitors, they should be stopped before any high-risk procedures, whether it's on the kidney or any procedure. Okay, the aim for urinary output is hopefully above 40 milliliters an hour and maintaining a mean arterial pressure of above 70. But remember, what is the formula I gave you for urinary output? 0.5 milligrams per kilogram per hour. That's what you should go by. All right. Now, what can we do to prevent nosocomial infections? Being judicious in using indwelling urinary catheters or Foleys. If they don't need one, then don't put one in. The only reason someone should have an indwelling catheter really should be that they can't get up and go to the bathroom themselves. That's it. So these people in ICU that are unconscious, okay? But people that can stand at the bedside and pivot and go into a bedside commode, yeah, that's what they should be doing for sure. Because the infection rate is still way too high. Using strict aseptic technique when all interventions lines, which means wash your hands and wear your gloves. Okay. And early detection of sepsis. Is there mental status changes? Maybe the blood pressure is a little lower than it was before. Those slight little things. All right, so how do we do this? Remember, pre-renal conditions are usually reversible if renal perfusion is quickly restored. So timely replacement of extracellular fluid and aggressive treatment of shock may help prevent acute renal failure, or AKI. Now, blood loss calls for a transfusion, whereas pancreatitis and peritonitis are usually treated with isotonic solutions, like normal saline. Hypovolemia from large urine or GI loss, hypotonic solutions, half normal saline. Cardiac instability, you can use positive inotrope agents like digoxin. This increases the force of contraction, which you guys already know. A preload and afterload reducer could be great. Aortic balloon insertion may happen if they have that bad of cardiac instability. Hypovolemia from massive vasodilation. Antibiotics if the patient has sepsis, isotonic fluid replacement also for that. Invasive hemodynamic monitoring could be valuable. Post-renal obstruction should be suspected whenever a patient has an unexpected decrease in urine volume. These may be resolved by insertion of a catheter or stent in the kidney. Common interventions for patients with ATN include those items listed on the slide that you have in front of you. Nurses really must focus on the efforts aimed at preventing, including recognition of patients' risk factors, removing potential contributing factors. For example, is there another antibiotic besides an iacin that you could give them? And rapid treatment at the first sign of onset. All right, so what do we use? Now, there's certainly medications I've listed. Okay, the use of diuretics can be controversial because we understand that this classification of medication does increase renal blood flow and GFR and reduce tubular dysfunction. But there's increasing evidence that they may actually cause excess diuresis and renal hypoperfusion. But we still give it because when you have a BUN that's slightly high and your creatinine that's creeping up but still within normal limits, a lot of times if you give a diuretic and just shock the kidneys with a little bit of Lasix, everything will start working. All right. Now, dopamine there, back in the day, would help with urination. We don't really use it much for that anymore. It's called low-dose dopamine, and we really don't use it because it does have an effect on the heart rate and the blood pressure. All right, if someone is on theophylline, it can be associated with development of tachycardia and dysrhythmias and seizures. Epoetin alpha is known to produce the side effects of hypertension. Therefore, this also requires very careful management. So all these medications are used pretty commonly, but it all can affect renal. So dietary. Okay. So this is just for your FYI, because you're going to see that in the hospitals because you will be back there eventually. All right. But it is a critical part of the general therapy. The energy that is required to break down complex materials in one with AKI is much higher than somebody with normal basal requirements. And those on dialysis need even greater energy needs. For example, there is a significant loss of amino acids and water-soluble vitamins in the diacylate solution that causes additional depletion for nutrition. So the overall goal is to maintain a nutritionally stable environment. This environment, all right, to prevent any further negative nitrogen balance or muscle wasting. It also improves the patient's regenerating capacity and resistance to infections. So up there is the recommended diet for kidney. Okay. Now you might say, wait a minute, if they're spilling proteins into their urine, what are we doing here? You still need protein for energy. Still need protein for energy. They need that. They have protein in their body, yes, but it's not being used effectively. All right. Fluid volume excess, if managed by dietary restriction of salt and water and the administration of diuretics, is great. Dialysis or other renal replacement therapies may also be indicated for control of this balance. Electrolyte imbalances are common in AKI. Sudden changes in potassium, the levels can be above 6.6. Remember what normal is. 5 is the high. Okay? Then it can cause dysrhythmias that may be fatal. Elevated potassium has a potential for heart blocks, asystole, flatline, or ventricular fibrillation. You may see such signs as muscle weakness, diarrhea, and abdominal cramps. Okay, so look over here to the right where you see in the middle, approximate serum potassium. There's a 4. Here's a 6.7. See what's happening with this T wave? 7.8, 8.9, and above 9. You see how it's getting all wonky? This is normal. And this can make a patient code. Well, it does make a patient code. No if about it. Now, another thing that can happen is hyponatremia below 110. It occurs as a result of water overload. As the nephrons are progressively damaged, the ability to conserve sodium is lost, and salt wasting state develops. These individuals have the potential to become lethargic, confused, comatose, and develop seizure activity. They often complain of nausea, vomitings, and headaches. That's it. Remember I told you low sodium was one of the biggest issues when someone's not acting right. All right, alterations in serum calcium and phosphorus occur often with AKI. These alterations are also a result of the changes in excretion, absorption, and metabolism of electrolytes. In states of hypocalcemia below 7, there is the potential for seizure, laryngospasm, stridor, tetany, heart blocks, and cardiac arrest. You may see a positive Chbosky sign. Remember that from block 1? That's the face where you're tapping. And Trousseau's sign, the hand. If you were to inflate a blood pressure cuff, it twitches back. Okay? Good way to check the calcium without knowing the level yet. You can know whether you're having a problem. You don't necessarily have a lab. Those are your assessment skills. Hypermagnesium may demonstrate as bradycardia, heart blocks. They might get lethargic, end up in a coma. They could have hypotension, hypoventilation, weak or absent tendon reflexes. Hypermagnesium is above 3. So, real problems with these people. RRT therapy, or renal replacement therapy. This is a conservative treatment for AKI. There is still a great deal of debate about the most effective time to initiate this. There are some common indicators during AKI that are listed on the slide. So remember that RRTs are used in chronic renal failure as well, and more commonly in chronic renal failure. When RRT is determined to be necessary, there are several options to consider. There's peritoneal access. It's obtained by inserting a catheter through abdominal wall. It's a process carried out in surgery with varying techniques. Patients may have their bowel and bladder empty, a weight must be obtained, and consent signed, obviously. Peritoneal dialysis allows exchanges of waters, fluids, and electrolytes to occur in the peritoneal cavity. This is a slower method than hemodialysis. The process occurs through diffusion and osmosis across the semipermeable membrane, peritoneal membrane, and capillaries. Solutes in water move from the area of higher concentration in the blood to an area of lower concentration in the dialyzing fluid. This is something people can do on their own. They do it at home. Intermittent hemodialysis is considered the preferred method to produce rapid changes. If you get someone in the hospital and they have a significant issue going on right then and they go into renal failure, we're not going to worry about peritoneal dialysis. We don't have time for that. So we will do intermittent dialysis, which is the most common, where they're either taken to a dialysis center, maybe they're at home and they go into it, or they come up to the floor. In ICU, they come to us. So the dialysis is happening maybe twice a day, maybe once a day for 3 hours, just depends. That's intermittent. That's on a machine. CRT is a continuous therapy with slower blood flow rates. CRT is continuous. It permits uremic toxins and fluids to be removed from the circulation. At the same time, acid base and electrolytes can be adjusted gradually, which may be critical for the hemodynamically unstable patient. These are patients who do not adequately respond to dietary interventions and drug therapies. Anticoagulation is required to prevent blood clotting during CRT, so they have to give heparin during these things. The scary thing is, when someone is on a CRT, and there's different names for them, but it is all the time, and these patients are extremely critical. A friend of mine, she's okay now. I don't know how, but she is. And she went through a very scary time with cancer. And she's only 3 years out, still on some medications, but they were doing her second chemotherapy. And she ended up septic in the ICU on a ventilator. She had CRT for, I can't even remember how long. I mean, it was over a week, maybe 10 days, which is pretty incredible. And the fact that she was actually in the ICU, I think it was 5 weeks. She was a 1-to-1, meaning she had a lot of needs for at least 3 of those weeks, if not 4. I can't remember. It was all such a blur. The fact that she even woke up and can function is incredible. But my point is, this was one nurse working the CERT machine and taking care of her, which is doable because the machines have gotten so much better. But it is a big deal when people are on these continuous. They are not doing well at all. Okay, so hemodialysis, look to the left. That is what it looks like. It goes into a fistula that has been placed in their arm, or it is going into the dialysis catheter, more commonly at the neck. So, just so you know, and peritoneal dialysis, there it is. There's the belly. Okay. Alrighty. Hemodialysis. There I put some complications. Hypotensive is big. When they come in to do hemodialysis, intermittent, for example, there will be a dialysis nurse and then the RN. In the ICU, for example, many times they're just going to take off fluid. Now, what we call taking off fluid means this, that when they're hooked up to dialysis, there is an order from the physician that says specifically, I want 3 liters off today. Let's just say that's the order. However, you as the bedside RN, you're monitoring. You don't have to stay in the room because a dialysis person will stay in the room. But in my experience, I've heard the alarms going off. I go in, I'm like, okay, they're getting hypotensive. You need to stop. And they'll turn the machine off. We'll try to get them back up and going. But many times, maybe they can only get 2 liters off. This goes into clinical judgment. This is what we keep telling you guys about having to really think through it. The order was for 3. If we take another liter off of this person, they could go into cardiac arrest. And I'm not overstating that. So guess what? We're stopping. And that is you as the bedside nurse. You're letting the dialysis nurse know. Now, the dialysis nurse also might go, hey, this is not working out, So then they will just notify the physician, or you'll notify the physician and say, this is why, and this is what happened. And maybe they'll come back another day, or maybe even a few hours. Whatever's going on with your patient. Okay? Now, dysrhythmias can occur during this time. A rapid shift in serum potassium levels can cause this. Clearance of any antidysrhytmic medications you gave them. Anything you give in the system, if it doesn't have time to metabolize, it's going to be sucked out by dialysis. So if you just hung an antibiotic 20 minutes before they got there, you might as well not have even bothered. So all you need to do is note that on the MAR. If you're late giving it, or you gave it early, to avoid that, you need to note that. Right? Now, cramping can occur during this because you're taking off large amounts of fluid, or they are. So just be aware of that. All right, vascular access. This is where you can see the real patients here through the neck here, through the chest. This is where it goes. Remember what I told you before. You never, ever, 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 ever access a dialysis catheter for any reason. None. Okay? None at all. The picture on the right here, this is called an IJ placement for a tunneled or cuffed catheter, if you remember that during our lecture before we left for COVID. B shows a temporary hemodialysis catheter, and C is a long-term hemodialysis catheter. Okay. The next slide is going to show you some more. This is very common. This is something called a shunt, or an arterial venous fistula. It's an internal surgically created communication between an artery and a vein. This method produces a vessel that is easy to cannulate, in other words, being able to start, but requires 4 to 6 weeks before it's mature. So they'll still have their access in their neck, or their temporary access in, until this matures, and it usually takes a month. Okay? Now, basically, how do you know this is functioning and working? Well, there's something called checking for the thrill and the bruit. You feel the thrill. In other words, you touch on top of the picture there where their shunt would be. Okay, so you're palpating the thrill. Feel the thrill. And it'll be bounding. Then you hear the bruit, or auscultate the bruit. Bruit is spelled B-R-U-I-T, but it's pronounced bruit. Feel the thrill. Hear the bruit. You put your stethoscope over the top, and you'll hear shoo, shoo, shoo. That means it's functioning. Also, you're going to look distal of the area. Are their fingers blue? Can they move their hands okay? Any extremity issues? Okay? That is your assessment. Feel the thrill, hear the bruit. Okay, so here is something called CVVH and CVVHD. Don't get hung up on this. These are just different things of CRRT that you might look into. They're just their filtration jazz is a little different, but don't get caught up on that. I just wanted to show you what they may look like. All right. So here again's a list and what they do right in here. Okay. Basically, you're just going to know CRTs are continuous. Okay. Renal transplants. Okay. So renal transplants are the therapeutic choice for patients with end-stage renal disease. If these people can get a transplant, then they'll be free of dialysis and manifestations of uremia. The survival after 5 years of a transplant is 85%, so that's pretty darn good. Recipients will be evaluated on a medical, immunological, and psychological status. Usually the recipient is younger than 70, and they have to have a life expectancy of at least 2 years. So even if 40 years old, I have to be reasonably sure I'm going to live 2 more years. But if I had a bunch of comorbidities, diabetes, hypertension, I've got cancer, they're not going to give me a transplant. Infection and active malignancy are the only two absolute contradictions. Now, when I said usually the recipient's younger than 70 and life expectancy of 2 years, it doesn't mean if you're 75, you're not going to get a transplant. That's just the norm. But the two things that absolutely rule you out, like I said, is cancer or an active infection. You'll reject the kidney. There's no reason to do it. Donors are either living-related donor or cadaver donor. A living donor is more desirable. Live donors also undergo physical and psychological evaluations. The kidney from a living donor functions almost immediately after transplantation. However, a cadaver kidney may not, requiring further hemodialysis until adequate functioning is occurring. You will be monitoring fluid and electrolyte balance, and I'll tell you guys right now, it is a specially trained area. You really need to know your stuff when you're going up there. And I say going up there because when I worked the floor below the transplant unit, so it was on 12 and I worked on 11 at Good Sam. Oh, sorry. Was it Banner Medical Center, Phoenix? Oh, it's Bump. Banner University Medical Center, Phoenix. That's right. Okay, that's Good Sam. All right. Patients with end-stage renal have chronic anemia usually, so therefore H&H levels are monitored for downward trends that may indicate bleeding. And that makes sense. The immune system is programmed to recognize a transplanted organ as foreign. Therefore, it requires to be suppressed, so immunosuppressant drugs are given. They will always take these. You will never be off these as a transplant. Okay. Complications that may occur could have acute tubular necrosis or ATN, urine leaks, renal arterial stenosis, infection. The most common cause of death after renal transplant is cardiovascular disease because of the comorbidity conditions that often exist in the patient. In other words, they've already got maybe one issue that caused the original, and then it gets all pumped up again. But basically, renal transplants can be very successful. The one thing I want to tell you about transplants, just in general, is if you are given an organ from a cadaver. Now, the thing about kidneys is obviously we can live on one kidney. But if someone needs a heart or something like that, the toll it takes on the recipient psychologically can be something, because they know if they got a heart that someone had to die for that. Unfortunately, people pass. Accidents, illness, whatever it is. So in the hospital, every patient that dies, every single patient that passes away in the hospital, you will call Donor Network. It doesn't matter if they are riddled with diseases. You are to call the Donor Network, or your charge nurse will, and every time you give them you answer their questions, and if they deem the patient okay, then they'll reach out to the families to ask about transplant, possible organ donation. It's up to them, but you call on every patient. And usually if they've died from multiple diseases, by the time you say one disease, they're like, okay, thank you for calling, and you're done, okay? All right. Nursing management. Preoperatively, you must understand that your patient may have waited years for this. So a thorough review of the procedure, including post-op expectations, should be discussed. The surgery itself usually takes about 3 to 4 hours. If your patient's on peritoneal dialysis, all the dialysate solution must be removed before going to the OR. Now, how do you do that? Don't get hung up on this, you guys. When they come in from home, usually they don't wear gloves at home when they're doing this. What'll happen is a cart will come up for the patient. Many times there's a step-by-step guide on the cart because we're not trained all the time, and it'll be years before you do it on patients. Many times the patient will tell you how to do it if you're not sure, but you will always glove up. It is not sterile, it's clean procedure. All right, your patient may require dialysis after transplantation, so the patency of the vascular access must be evaluated and maintained. They might need another dialysis afterward, especially if it's a cadaver kidney. Postoperatively, urine output may be as high as 1 liter, but it should progressively decline as the BUN and serum creatinine levels return to normal. Okay, there's all the complications. The biggest issue for them psychologically and physiologically is rejection. All right, chronic kidney disease. It's insidious. Now, we just talked about transplant that is in the chronic renal area. It's irreversible destruction of the kidneys. Okay. Predisposing or precipitating factors could be recurrent infections, exacerbations of nephritis or an obstruction, long-standing hypertension or diabetes resulting in blood vessel destruction, or direct insult to the kidney, or there's trauma. Okay, so it says normal there, above 90. Actually, in chronic kidney disease or failure, this is actually called at risk. At risk. Because it's starting. It's starting right there. Okay, so what do I want to tell you? Oh, yeah. I sort of lost my train of thought. I'm sorry, you guys. Oh, I know what to tell you. All right, so over additional time, the disease progresses to severe, the 4th stage, and end-stage kidney is the 5th stage. By this time, excessive amounts of urea and creatinine build up in the blood, and homeostatic capabilities decline. Severe fluid and electrolyte and acid-base imbalances occur, and without any renal replacement therapy, like dialysis, the disease becomes fatal. You need to be able to get rid of your waste. All right, the reduction of a GFR that accompanies kidney failure produces a multitude of problems. Urine production and water excretion are affected, and electrolyte and metabolic abnormalities occur. Because the healthy nephrons become larger and work harder, the kidneys can maintain an effective GR until 3/4 of the kidney function is lost. So they may look like they're rocking along and then boom. As the disease progresses, the ability to produce dilute urine is reduced, resulting in urine with a fixed osmolality. Okay? That's isonaturia, the last one from the bottom. The 1, 2, 3, 4, the 5th one down. As kidney function continues to decline, the BUN increases and urine output decreases, placing the patient in risk for fluid overload. Not surprising, they're retaining fluid. They can't urinate. Okay, so I told you the metabolic changes in the chronic is pretty much the same as in acute, only the chronic's not going to get better. Okay, so that's basically it. Now, this demonstrates the effect of chronic kidney disease on phosphate and calcium balance. There are several reasons why the increase in PTH is common with kidney failure. The diseased kidney cannot activate vitamin D. Without activated vitamin D, calcium cannot be absorbed from your intestines into your blood. When the blood calcium level drops, the parathyroids respond by producing more PTH. Okay? This sends stored calcium into your blood, which weakens the bones. or supplements has to be converted by your kidneys so that the bones can absorb calcium. With kidney disease, the process doesn't work very well, so your bones can't absorb the calcium. They need to replace what was sent to the blood. That's how it works. That's it in a nutshell. Okay, so hypertension is common in most patients with chronic kidney disease. This can be either the cause or the result. In patients who have other causes of hypertension, the increased blood pressure damages the delicate capillaries in the glomerulus and eventually end-stage kidney results. So chronic kidney disease itself elevates blood pressure by causing fluid and sodium overload and the dysfunction of the renin-angiotensin-aldosterone system, which we talked about a while ago. Retention of sodium in water causes circulatory overload, which elevates blood pressure. It makes sense. You have fluid that you don't need in your body, and that's going to make you hypertensive. Hyperlipidemia occurs in CK from changes in fat metabolism that increase triglycerides. It increases total cholesterol, and so that's not surprising to see in these patients. Now, if they have these changes, it increases their risk for coronary artery disease and acute cardiac events. The hypertension, anemia, and fluid overload that occur in CKD increase the workload on the heart. So left ventricle enlargement and heart failure are common in end-stage renal disease. Pericarditis is also fairly common as a result of the uremic toxins or infection. This can lead to pericardial infusions, cardiac tamponade, and death. Boy, that was a fun slide, wasn't it? Jeez, it was very morose. Okay. Other changes, the causes of anemia include decreased erythropoietin levels, or EPO. That decreases the RBC production, the red blood cells. Decreased red blood cell survival happens, and increased bleeding as a result of impaired platelet function. Normal flora of the mouth changes with uremia. So the mouth contains an enzyme called urease, which breaks down urea into ammonia. The ammonia generated from this reaction causes halitosis and stomatitis. Uremia is responsible for anorexia, nausea, and vomiting, potentially related to high BUN and creatinine levels, and acidosis. Ulcers formation may occur in the stomach, small intestine, or large intestine as well. This is where you get your peptic ulcers. Okay, assessment. When taking a history from a patient that you suspect has chronic kidney disease, focus on the manifestations of the disease. When taking a weight measurement, for example, ask about unusual weight gains or losses recently. Weight gain might be the result of fluid retention, and loss may reflect anorexia from an elevated BUN. You will want to obtain information regarding past or present renal diseases, medication usage, and family history. A change in the taste of food often occurs with CKD. Patients may report that sweet foods are not as appealing or that meats have metallic tastes, both the result of the accumulation of excess waste products. Energy level declines from impending pulmonary edema, recent injuries, any bleeding episodes can result in hematological changes from uremia, must be identified. Now, chronic kidney diseases causes changes in many body systems. Many manifestations are related to changes in fluid volume, electrolyte and acid-base imbalances, and buildup of nitrogen waste. Examples, nausea, vomiting, lethargic, decreased concentration, seizures, slurred speech, ataxia, which is altered gait, your cardiovascular system, hypertension, peripheral edema, heart failure. This is not any different than acute, but I'm just going over them again. Respiratory, shortness of breath, could have Kuzma respirations. Hematological, they could have edema, bruising. GI, the good old standby is nausea, vomiting, diarrhea, constipation. GU, polyuria, oliguria, proteinuria, not surprising. Okay. A late sign is usually your skin. You have decreased skin turgor, Uri McFrost, and your musculoskeletal, muscle weakness, and reproductive. If this is in childbearing women or men too, you have a decrease in fertility. And women, you have infrequent or absent menses, and guys, impotence can occur. Here's a picture of uremic frost. The frost consists of a white or yellowish coating. Now, these are urea crystals. Okay, it can be on a man's beard, it can be other parts of the face and neck or the trunk. It is due to a deposit of urinary crystals on the skin surface from a patient with severe uremia. So these are this is byproducts of urine on their face. That's basically what that is. We talked about a little bit about the psychosocial issue when we specifically to transplants, but this goes over different things, and different things that also can happen to the body. Everything can happen, but let's look a bit psychological. Could you imagine being hooked to a machine and having to go in 3 days a week for 3 hours out of your life? And it's not always an optimal appointment. You could be going in the middle of the day. You're limited on what you can do. It's really terrifying. It really is. Not to mention how people feel if they have to be taken care of. Most people don't want to be taken care of, believe it or not. They really don't. Okay? I'm going to tell you really quick. This gentleman was in the ICU, and he wasn't my patient that particular day, but he actually was doing very well. He was alert and oriented, but he still couldn't move very well. So he had stooled. Not a big deal to us as nurses. The other nurse asked me to come in and help, so she turned him toward her, and I was cleaning him up. And she looked at me and she whispered, "He's crying." And I said, "Are you doing okay? Am I hurting you?" And he goes, "No, I just can't believe you gals have to clean me up." And everything he went through with his disease process and everything, that was his concern. And of course, you guys probably know me well enough by now. My reaction was, "Don't worry about it. Nurses love pee and poop. We're all about the pee and poop." And he started laughing. Because I did tell him also, I said, "Look at you. You're actually holding yourself up. You couldn't do that yesterday." So it's those little achievements that we also need to remember as nurses that we need to allow our patients to have, for sure. Now, these are most of the labs you'll want to consider when reviewing. Remember, CKD causes extreme changes in many lab values. In the older stages, your analysis may show excessive protein. When kidneys are diseased or damaged, they don't make enough erythropoietin. Okay, that's a hormone made by the kidney. As a result, the bone marrow makes fewer red blood cells. All right, GFR is calculated on a certain level. Basically, what I want you guys to know in this is what happens. Serum creatinine is increased. BUN is increased. Serum sodium can be either one. Serum potassium. So take a look at this and make sure you know it. Okay. All right, planning care. Nutritional intake is often less than body requirements normally because you're just not hungry. Therefore, dietary planning is super important. They need protein, sodium, phosphorus restrictions could be necessary, but not crazy. Vitamin supplementation is required for most patients. Potentially manage excess fluid volume. So these are the guys that are on fluid restriction. Can you imagine only having 32 ounces of fluid a day? I drink that on the way into campus. That's insane, right? That's horrible. And you have to take that into consideration if you're giving an IV fluid as well. It's kind of crazy. All right? They could have long-standing, could have brittle or fragile bones, fatigue. It is the nurse's responsibility to coordinate a team of care professionals to support and counsel the patient, and family frequently. Because we're the ones that have most contact with these guys. All right? So we need to constantly assess them for early signs of any pulmonary edema. So are they restless? Do they have anxiety? Was there any changes in their mental status? So we don't lose them. Okay? Urology department, can you hold? I thought that was cute. Anyway, you guys, that's it for the lecture. Certainly make your notes. And then next Thursday, is it next Thursday? I can't remember. Yeah, there's a 10 a.m. on the 9th. So with the questions, concerns, but also feel free to email me questions. I certainly don't mind that, and I might post stuff, answers in the announcements. I think that's most effective. So anyway, you guys have a wonderful night. Stay safe, and I will talk to you soon.